Search streaming. Okie dokie. Looks like we're going live on YouTube. Okay. Good evening, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Tonight I'm talking about Addison's disease. The title is all about Addison's. Addison's is not a super common disorder, but I think it's good to talk about with the global interest in autoimmune diseases. More and more people not feeling well, more and more people looking into their own symptoms as to why they're not feeling well. And so there's a lot of research going on. So hopefully I can provide some clarity on this condition as well as its associations with other autoimmunity or other autoimmune conditions, so to speak. Okay. All right. So this slide here is from the Principles of Neuroscience. It's demonstrating what is the sympathetic nervous system and your parasympathetic nervous system. Because Addison's is a disease of the adrenal gland, it's the most common cause of primary adrenal insufficiency, that we probably want to understand how the adrenal glands work and what parts of our brain and body communicate with them. As you can see here in this diagram, this is the adrenal gland. Here they're labeling the adrenal medulla because that's what receives direct sympathetic innervation. And so we'll pause there. So think of your adrenal gland as a basketball, or think of it like the earth. So the outer crust of the earth is analogous to the adrenal cortex, and the inner core of the earth is analogous to the adrenal medulla. The adrenal gland is a weird tissue, as I often say, because it's one of a few tissues, in fact, I think it's the only one that I know of, where it has a neurological and an endocrinological embryologic origin to its nature. So the center of the adrenal gland is neurological tissue. The outer portion of the adrenal gland is endocrine tissue. So that's where this is kind of a peculiar relationship. And I'm going to pause right there and just say hello to everyone who's joining. And thank you so much for the hellos. So nice. I feel the love. So continuing on, the outer portion of the adrenal gland is the adrenal cortex, which is principally involved in Addison's disease, where we have a failure of that endocrine tissue to produce hormone. The adrenal medulla, it seems for the most part, is still working, so we're still able to make adrenaline. I think not everyone is aware of how vitally important adrenal hormones really are. And without adrenal hormones like cortisol and or aldosterone, we can easily die and go into an adrenal crisis. And that's where Addison's disease is so dangerous if someone reaches that point. So at the end of this, you'll know the symptoms and the signs. You'll know the causes. We'll go through all of that. Simply now, as we think about the adrenal cortex, we have different hormones being produced from the adrenal cortex. We have cortisol, as I mentioned. What does cortisol do? It dampens immune responses. It's involved with mobilizing glucose stores from your liver, so that if you're fasting in the desert, or even if you're sleeping during the middle of the night, you're going to be able to get glucose to your brain. If the fast goes on, then you're going to start doing a process called gluconeogenesis, and cortisol is instrumental in that. Cortisol does a lot of other things, but those are some of the biggies. And then you have aldosterone. Aldosterone, if you remember from the POTS broadcast, aldosterone saves sodium at the level of the kidney, and it basically saves sodium and get rid of potassium. So we want to bring sodium back into the bloodstream and get rid of potassium. So aldosterone is a hormone that's designed to increase blood volume, and if your aldosterone is low, then there's going to be a tendency to go into what's referred to as hyponatremia, and you're going to basically, for all intents and purposes, pee out excessive sodium, and you're not going to have enough sodium in your blood, and that can cause some really significant consequences. So aldosterone is really, really important. We also have 17-hydroxyprogesterone produced in the adrenal glands, and DHEA. DHEA has its own functions. It goes a bunch of different directions, but in, for example, postmenopausal females, DHEA turns into estrogen at physiological levels. So that is the adrenal cortex. So Addison's disease is a disease of the adrenal cortex. It's referred to as primary adrenal insufficiency. What is an example of secondary adrenal insufficiency? That is where, for example, someone has a very severe head injury and their pituitary stops working correctly, so they don't produce the hormone from the pituitary down to the adrenal glands, which is ACTH, in proper fashions, or in proper amounts. So that can result in secondary adrenal insufficiency. Let me take a drink. Addison's disease is more common in women than men. It affects 10 to 30-year-olds most commonly. It's not super common, but still present in about 90 to 220 people per million in the population, which is a fair amount. So if you think of an area like Las Vegas, where there's about 2 million people, somewhere between about 200 to 450 people down there are going to have Addison's disease. So doctors probably will see it, but it's not something like autoimmune thyroid disease, where maybe 1 out of every 3rd female who's around the age of 50 may present with that. So in terms of symptoms, Addison's patients present with fatigue, nausea, dizziness, and they're probably losing weight. And so if someone's going into an acute crisis where they're just fatigued and they're nauseous and they're dizzy and they're losing weight, the next thing to do is to go to the emergency room, and usually they're going to run a blood panel, and immediately it will probably become apparent that their sodium levels are way off, maybe their potassium levels are off, which will then result in the diagnostic process. That's most commonly probably how it goes. Addison's patients crave salt. So based on this, the functional world has said that if you are craving salt, then you have an adrenal gland problem. And they're not entirely wrong, but it's more that you have a brain problem. When what most people refer to as adrenal fatigue, it's really hypothalamic fatigue. And you can watch my chronic fatigue broadcast on that. Hyperpigmentation is a really important feature of Addison's disease. So we call it hyperpigmentation of the mucosa in the mouth. There's another name for it, which I won't go into. But if you have a bunch of dark spots inside your mouth, that can be a sign of Addison's disease. The reason why that happens is because as the adrenal glands fail, just like if your thyroid, if you have Hashimoto's thyroiditis, for example, and your thyroid is not producing thyroid hormone, what happens? Your pituitary sends excessive signals of TSH down to your thyroid, telling the thyroid gland, gosh darn it, do your job. Same thing happens with Addison's disease. The adrenal cortex, as I mentioned, is failing, and so the brain is going to secrete a ton of ACTH, trying to get that adrenal gland to produce adequate amounts of cortisol and other hormones. And in that process, ACTH stimulates melanocortin receptors, and melanocortin leads to hyperpigmentation. So that's where you can see hyperpigmentation in Addison's disease. Sometimes you may see it in the hands, I believe, as well. In terms of a laboratory assessment, you're going to see high ACTH, low cortisol, low sodium, and you may see the presence of adrenal antibodies. In fact, most likely you are. I'll talk about that later. The medical therapy is basically to replace cortisol and aldosterone. The cortisol is typically replaced in hydrocortisone, and aldosterone, there's a medication called fludrocortisone, which replaces aldosterone. Aldosterone is a mineral corticoid. It's referred to as that because it is involved with bringing minerals back into our body. Cortisol is a glucocorticoid because cortisol heavily affects glucose metabolism. So here's just a nice little diagram of some of the triggers, so to speak, For Addison's, here you see the adrenal cortex. It looks kind of like a triangle. I described the earth, but it kind of looks like a triangle. Out here is the cortex. The inner part is the medulla. Then we have genetic predisposition. That can be a big factor. The genetic predisposition for Addison seems to be through HLA alleles, so human leukocyte antigen. Some people are just more prone for certain autoimmune diseases, and that's where the genetic predisposition comes in. Environmental factors, I'll talk about that soon. Autoreactive T cells, autoantibodies, and maybe some sort of immunization may be involved too, as they're saying in this article. Here's the citation. Okay, so in the past, tuberculosis used to be the most common cause of Addison's disease. And so with that, with tuberculosis, it's still pretty common, but they're now saying that this isn't the most common cause of Addison's disease. Most commonly, it is the autoimmunity. 95% test positive for anti-adrenal antibodies at Diagnostics. These are referred to as the 21-hydroxylase antibodies. The cytochrome P450 21-hydroxylase enzyme, that's a big mouthful, but just know we have a bunch of enzymes called cytochrome P450 in our body. A lot of them are involved with steroidogenesis, so producing hormones. Others are involved with like liver detoxification. So when people say, you know, I can't detox, what does that mean? There's technically two stages of taking a toxin and making it water soluble. The first one goes through cytochrome P450 enzymes. The second one is based in glutathione and glucuronidation and methylation pathways. Nonetheless, this 21, I think it's the 21 alpha hydroxylase enzyme, but a lot of people just call it the 21 hydroxylase, is the antigen for Addison's disease. So what I mean by that, I mentioned that the adrenal cortex is getting attacked. Well, the immune system is more appropriately seeming to attack this 21 hydroxylase enzyme, and that 21 hydroxylase enzyme is critical in the biochemical pathways for producing cortisol and aldosterone, particularly. So that's where that is really significant. Let me see, I lost my place. Half of Addison's have other autoimmune diseases. Thyroid being high or low is very common. So a lot of them have Hashimoto's or Graves' disease. Addison's patients may have type 1 diabetes, and they may also have autoimmune gastritis. The triad, so to speak, of autoimmune thyroid disease plus autoimmune adrenal disease and type 1 diabetes equates to autoimmune polyendocrine syndrome type 2. There are all these autoimmune polyglandular syndromes. You can look them up, but it's basically if you have this autoimmune disease and this one, then it's this type of autoimmune glandular syndrome, polyglandular syndrome, so to speak. So nonetheless, just keep in mind, if you know someone with Addison's disease, it's very probable that they may, in fact, have other autoimmune problems. So if you know someone with Addison's, they may have other autoimmune problems. The heritability is high, involving what I mentioned, the HLA alleles. 90% of the adrenal glands can be destroyed by the time of diagnosis. So I think that's important too. So by the time someone presents to the emergency room with horrible fatigue and they're nauseous and they're dizziness, they have dizziness and they've been losing weight and they've been craving salt and they haven't noticed that they're developing all this hyperpigmentation in their mouth, at that point, upwards of 90% of their adrenal glands are destroyed in terms of the adrenal cortex. And this is common with autoimmune disease. And so often individuals out there are saying, well, I'm taking levothyroxine in the case of autoimmune thyroid disease. I'm taking levothyroxine, and can I get my thyroid function back? And what I found is there seems to be a critical point where once somebody's taking so much hormone, the thyroid is it's been damaged, and they probably will have to keep taking that based on my experience. And there's discussion in the literature about some Addison's patients still retain some adrenal gland function, and there are even studies where they use immunotherapies like rituximab, trying to reduce the autoimmune inflammation, analogous to what you're seeing every night on television for rheumatoid arthritis and Crohn's disease and psoriasis with all these biologic medications. the same line of thinking is being employed that maybe we can do that with Addison's disease. But again, Addison's is not that common, so there may be less of a reason or initiative, so to speak, to do it. T cell and B cell responses are against this 21 hydroxylase. They basically figured this out by researching mice. It was really difficult to figure this out in humans. So for those of you who watched the research, how to research like a professional broadcast, I went through reasons to do studies of mice versus humans, or methodology. And then a viral trigger seems to be a precipitating event for some Addison's patients. There's a lot of research on cytomegalovirus and herpes simplex virus type 1 reactivations, and maybe that is the trigger for the immune system to start attacking the adrenal gland in a genetically susceptible person. But there is also information on gluten. And so this is out of the World Journal of Gastroenterology, 2016, where they said, and others presenting with now here they're basically just talking about celiac disease patients. But they said, particularly in type 1 diabetes, autoimmune thyroid, or other autoimmune endocrine diseases such as Addison's disease, basically that celiac disease is present. So if you take type 1 diabetes patients and autoimmune thyroid patients and Addison's disease patients, if you screen them for celiac disease, they will show up as having celiac. And they basically go on to say that adrenal insufficiency and celiac disease may occur in some patients. Indeed, a high frequency of adult celiac disease may be present in association with autoimmune adrenal cortical failure, autoimmune Addison's disease. So that's pretty interesting. So hopefully you take some information home from this. We had a question: what diagnostics are indicative of adrenal gland destruction? Great question. So the diagnostics typically are, you see a patient who has low sodium, they have those other symptoms like I mentioned, and usually the sodium is really low. It might be, for those in the medical world, it might be around 120 or 119. It's typically below 130. And then they're going to have the 21 hydroxylase antibodies. They're going to have high ACTH, low cortisol. Those are going to be the primary diagnostic tests that are going to show up. So yeah, so send me your thoughts, your questions. Again, I hope this was helpful, and I hope you all have a lovely Wednesday evening, and I will see you soon. Okay.